welcome to today's webinar on how health facilities can reduce their environmental footprint. If you're joining us today, you are aware that climate change is one of the main challenges facing public health today, with the direct and indirect effect it has on health. So it's a public health challenge, but it's also a health systems challenge, because of course our health systems need to adapt to ensure that they keep providing the necessary services. At the same time, though, health systems themselves are quite a burden to the environment. There are estimates that say that they produce about 5% of global greenhouse emissions. And obviously, if we think about it in a holistic way, we need to act in several directions, not only to ensure that we absorb the different demand that comes with climate change, but that we ourselves, from the health system perspective, do everything we can to reduce our contribution to climate change and to its effects, of course. So in today's webinar, we will talk about the role of health facilities and how they can reduce their environmental footprint within this overall context. I'm really happy to be joining you all today on this. My name is Dimitra Pantelli. I work for the European Observatory on Health Systems and Policies, and I will be your moderator today, together with my colleague Erica Richardson, who will be keeping an eye on the chat and joining us later with some insights from your discussions. We have a stellar lineup of speakers today around this topic of greening health and especially health facilities. We will start with Nicole Maurer, our own from the Observatory, who leads the work on climate change and health together with me. We have Maria Gaden, who is the Chief of Development at the Center for Sustainable Hospitals at the Central Denmark region, and on the board of Healthcare Without Harm. We have Philip Eigner, who comes to us from Solve in Vienna with some experiences on hands-on experiences from greening projects. We have David Dalmau-Manola, who is the director of the chair in health and climate change at the University of Barcelona and Mutua Terrassa. And we have Dorota Jarosinska, who comes to us from the WHO European Center for Environment and Health in Bonn. So a lot of really interesting insights, but of course we also have many of you. We're very happy to see you, and we will be keeping an eye on the chat. So a couple of housekeeping rules in that sense. Please put your insights, your comments, your questions to our panelists in the chat. As I mentioned, my colleague Erica will be keeping an eye on that. We will hear from all of our speakers, and then we will bring you in later, or bring in your insights that Erica will communicate to everybody else. So we're really looking forward to a lively discussion and to important insights on this really crucial topic. It will be a pleasure to collect all the different insights that you will give to us, and also, of course, our speakers first and foremost. Without further ado, I would like to pass to Nicole for her introduction to the topic today. So Nicole, go ahead.
Thanks a lot, Demi. Let me see if I can share the right screen with you all. I'm very, very happy to be here today and to have the opportunity to briefly present to you our recent policy brief, which looks at how healthcare facilities can reduce their own environmental footprint and what they can do to make health systems more sustainable. And we published the policy brief together with an infographic that summarizes the key messages from the policy brief. And I'm going to use this a bit as a support tool to structure my presentation, and also to guide you through the publication, and also to make sure that I don't go too much over the 10 minutes that I've been allotted for this presentation. So first and foremost, most people who have joined this call today will be aware of the importance of this topic, and Demi has already mentioned this, but just to reiterate that climate change has a very substantial impact on the health sector, and this is increasingly the case, but at the same time, it's also a bidirectional kind of relationship where the health sector also has a huge impact on climate change, and it is one of the most polluting sectors and estimated to be responsible for around 5% of global greenhouse gas emissions. So this relationship is a complex one, and this figure from the WHO operational framework for building climate resilient and low carbon health systems, which we also cite in the brief, shows this quite nicely, where we see that the health risks associated to climate change and the adverse health outcomes, including heat-related illnesses, vector-borne diseases, increased and increased non-communicable diseases, mental health impacts, and at the same time, the range of different actors that are exposed and vulnerable to these changes. But on the right side, we also see that health systems and facilities contribute directly by posing environmental threats and by generating GHG emissions, thereby fueling climate change at the same time. Because this is such a complex relationship and impact is seen at all these different levels, decarbonization must be pursued across the entire sector and at all of the levels, from the system level down to the healthcare facility level. At the system level, this entails shifting away from hospital-centric and curative care more towards promoting preventive efforts and health promotion, reducing unnecessary services and low-value care, and bringing services closer to people, as well as making more environmentally friendly and conscious decision when it comes to care delivery. So these changes at the system level do have potential to generate co-benefits both for the environment and population health, and they add to this long-standing argument that we see for improved quality, efficiency in the health system, and now also increased sustainability. And I just wanted to mention this other publication, a review that came out in Health Policy recently that looks at the role of the health sector in tackling climate change, which we also cite in the brief. And again, it shows the mitigation strategies at system level. If we look at the demand side, where reducing avoidable demand and unnecessary services by strengthening prevention, by strengthening patient education and health literacy can contribute towards better health and climate outcomes. On the supply side, low value care, so minimizing low value care, overdiagnosis and treatment, and also making more environmentally friendly choices in care delivery, such as using greener medical products as alternatives or moving care to less polluting settings when that's an option, as for example through telemedicine or services such as hospital at home, can be beneficial and generate significant co-benefits. At the healthcare facility level, there are also very concrete interventions that can be pursued. A large proportion of the emissions that are generated are actually generated within facilities themselves because they consume large amounts of energy. They need to function around the clock. And I'm going to go into each of these bullet points on the next few slides, but just to say that there is a broad scope for intervention that ranges from the types of products that we purchase and how we approach procurement to how patients and staff travel to and from hospitals, how the physical spaces are in which we deliver care, and obviously underlining all that, how we empower health workers to implement these changes and to be agents of decarbonization. So starting with infrastructure at the top left, this is within the direct control of many facilities because they decide how the spaces in which they deliver services look like. So when it comes to existing buildings, we can make them more energy efficient. Examples include substituting lighting with LED lighting, or implementing heat recovery systems and making ventilation systems more energy efficient, or creating green spaces to have a natural cooling effect, for example, on roofs. We can also switch to renewables to some extent. So the introduction of solar panels is often cited in the literature. And then when it comes to new builds, it's about following strict environmental standards and sustainable building designs. The second area that we mentioned is green procurement. This one is also key. We know that around 70% of emissions come from the global supply chain, and it is to a lesser extent within the direct control of the facilities, but they can, at a small scale, make a change by adopting environmental standards when they select which kinds of products to purchase. For example, this applies to pharmaceuticals, to medical devices, to medical equipment, but also to non-medical equipment and supplies, as for example, the food that is served or the construction materials that are used to build new facilities. Transport is another area where facilities can influence how patients and staff travel, but they can also switch their own vehicles, because many facilities own their own vehicles, towards more environmentally friendly options, such as electric vehicles. But as I said, they can also influence how other people and also how other people travel to and come from facilities. For example, they can collaborate with local governments to improve public transport options, or they can implement car sharing or bike sharing models. So there are a range of different options that are explored here, that are explorable here. And lastly, the area of waste management. We know, again, that a large proportion of the waste that is generated is non-hazardous, which means that a share of that can be reused and recycled. And in the brief, we talk about this concept of the 3 R's, and there's also some extended concepts of that, the 6 R's. And the key takeaway here is really to implement these principles of circularity in daily processes, in clinical practice, and when it comes to waste segregation, how we try to reduce waste and how we dispose of waste. Last but not least, the health workforce is the key pillar that implements these changes. So we need them to have the adequate support in order to do that. This consists in communication and information campaigns to raise the general knowledge on sustainability, but also offering the right training opportunities and capacity building opportunities, including creating dedicated roles within organizations, such as sustainability managers. And here I just wanted to plug another Observatory brief that colleagues have produced that looks at green skills for the health workforce. So the second section of the brief presents specific case studies where we look at local, regional, national level, what different countries have done. And I'm really happy that we have some of them represented here on the panel today. So you'll hear more about these case studies in a minute. But just to say that one of the takeaways is from these case studies was that action at healthcare facility level is often possible, but it does require the adequate supportive environment for that to be made possible. This includes legal and strategic frameworks, but also the adequate resources, so funding and technical support. We provide in the brief a list of non-exhaustive resources, including what the international community offers. Key actors here are clearly the WHO, the EU, but there are also many others. And we also see that cross-country learning and collaboration can be instrumental to making change happen in this area. And just to briefly mention WHO as a central actor in providing technical guidance, in convening these collaborative fora, and also providing training opportunities. This is just one of the key resources that I already cited previously, which is the operational framework for building climate resilient and low carbon health systems, which provides very practical guidance on how to design and implement these kinds of changes in practice. And at the EU level, we have in the brief this figure, which shows the range of different funding instruments that are available, also technical support instruments, which can support greening initiatives within health systems. And this mapping was produced within the scope of a broader EU project where we had Belgium, Slovenia, and Austria join forces. And Austria specifically made use of technical support through the digital, the DG, now it's called SG reform, at the European Commission, to explore how to make better use of EU funding instruments specifically for greening, to support greening initiatives in healthcare facilities. And I'm very happy that we, again, have someone today, Philip from Austria here today, who will tell us a little bit about the Austrian experience and how they've tried to leverage EU funding for greening initiatives. That's it from me. Thank you very much, and looking forward to hearing from our spotlight speakers. Thank you.
Thank you very much, Nicole. I think very clearly highlighting the different levels of potential action and then zeroing in on the health facilities, very helpfully disaggregating the different areas and the different possible sub-actions under those areas at the health facility level. And then, of course, clearly highlighting both that there is technical support around at different levels and that there is financial support around. Of course, that's not always very easy. We will talk about that, as we said, in a minute with colleagues. So thank you very much for that. You mentioned that we have case studies in the policy brief. We'll talk to two of our colleagues in a minute. Before that, though, we will move from the Observatory Central in Brussels to Denmark and to Maria, who has personal experience from implementing strategies for reducing the environmental footprint at the health facility level, and who will enlighten us about how we can go about doing that. So Maria, thank you very much, and over to you.
Thank you, and thank you so much for the opportunity to speak, and thank you to all of you for all the efforts that's been put into making this excellent policy brief. Now in Denmark, we also have national strategy with quantitative goals for CO2 reduction, and we have lead functions divided between the 5 regions. But what I will spend my 5 minutes to talk about, and what I've been asked to talk about, is a very concrete case. It is these metal instruments, and they are a dear friend of mine. I have a clinical background as a midwife, been working with these, and we made the first LCA on these metal instruments in 2022, showing that a shift from single-use to multiple-use metal instrument would provide a 90% CO2 reduction and a neutral financial business case in our conditions in Denmark. So since then, we've been working on how to implement, among other things, this product. And we've been doing it from a bottom-up perspective, from a top-down perspective, and currently I'm doing an industrial PhD in collaboration with Copenhagen University on implementation science, where these instruments are one of the cases. So I chose them not just because they're a dear friend of mine and we've been working with it, but because they somehow, in a very excellent way, reveal the complexity and the dependencies when we want to make these changes, even with quite simple products. So I will now share my screen. If we start out in the clinical perspective, of course, every clinician holds a responsibility and a potential to drive the change. They can request multiple-use metal instruments, and they are actually motivated to doing this because it makes sense not to throw out steel in the bin, and because it is a better quality that makes it easier for them to provide good health for the patients. So what usually happens is they somehow request the procurement department to buy multiple-use instruments. That is not always just a blink of an eye. In every switch from single to multiple use, there are regulations surrounding the whole tender and procurement area, of course. But another potential barrier are the hospital's capacity for cleaning service and sterilization. And of course, there are also the finances. There is a price for multiple-use instruments, and the financial structures within a hospital and departments varies. But either way, when you want to switch from single to multiple use, it demands an initial investment, and usually hospitals and hospital departments are working with one-year budgets, making it very hard for them to make this investment, even though they want to, even if the product is on the market. Now, the limitation of capacity could be solved by external sterilization capacity. Now, the market is not quite there yet, and sometimes it's better to do it locally. But if we're talking about more complex instruments than scissors and tweezers, it is a necessity to do it with external or at external reprocessing facilities. However, there are, of course, some finances connected to these switches as well, and we need to figure out what are the right business model in order to make both sustainable procurement processes for the hospitals and sustainable business model for the companies. And there are a lot of regulation right now, sometimes making it illegal to reprocess equipment that we know it is actually possible and safe to reprocess and use again. Now, this leads us to the producers, because really we need to have a production of multiple use instruments in the first place, not just concerning the scissors and tweezers, but all sort of medical equipment where it is possible. There's a lot of regulation here going on as well. And right now, the incitement structure is pointing in the wrong direction, because it's much easier and much cheaper for a company to get the right approvals on single-use equipment than it is for multiple-use equipment. Now, these processes, of course, again, affects the price on the products. in the market. Another thing affecting the price on the market is the global situation. The demands for steel, instrument and medical equipment in total is going up. Low and middle income countries are outscaling their healthcare system, which of course is good, but the demand for every product is going up, and at the same time, the resources are going down. We only have a limited amount of steel on the planet. So this, of course, affects the price on the market. But climate change itself, as it has already been said, has this interdependency with not only health, but also the whole supply chain. It is more complicated to withdraw the raw materials. The whole logistic around the globe is more complicated. So we are really vulnerable as it is today, and we simply need to change our pattern of linear consumption to a more circular consumption and not being dependent on daily deliverances of metal instruments and many other products if we want to secure health in the future. We could take the straw as an example. Sometimes it is possible to abandon a single-use product from the market. It's not easy, there will be resistance, but maybe we should consider not just prohibiting straws, but maybe also single-use steel instruments. Really, what I'm trying to say is that it's not just a matter of the clinical perspective and the workforce driving this change, even though there is a potential there. It's not just a question of the hospitals doing top-down decisions and stepping up. It's not about the procurement department just asking the right demands. Sometimes they can't even make a demand if the product is not already in the market. It's actually illegal for us to demand a multiple-use version of it. It's not just a matter of the market, then again, just making the change and taking their responsibility. Really, it's a matter of a systemic change. So what we need is leadership and policy level decision to make a transformation that makes it sustainable to continue providing health and healthcare all around the system of healthcare. Thank you.
Thank you very much, Maria, for the really interesting case study, for the beautiful visual, and also for the key message that you need different stakeholders all working together. So we do need the professionals in the health system who will come up perhaps with the ideas of what can be done to be less environmentally burdensome, but then we need the system level action to actually implement at all and at scale much more so. So I think that was a very nice way of summarizing it. Thank you very much for that. I pick up the point you made about the neutral business case. We keep it for now, and we'll bring it back when it's time for the discussion, because I think that's, as you mentioned as well, quite a sticking point in many times when we try to implement something new. So let's keep that in mind, and we'll come back to you in a moment. Thank you very much. We move from Denmark to Vienna, where Philip will talk to us about his experience, perhaps exactly not with making the business case, but with finding the support necessary to actually implement changes at the facility level. Philip, over to you.
Thank you very much. As Nicole Maurer has already announced beforehand, I had the pleasure to support healthcare facilities in Austria in seeking EU funding in the course of a TSI project together with the Austrian Ministry of Health. And I will now very quickly introduce one of those projects to you, which is the reconstruction slash refurbishment of the Health University of Applied Sciences in Tyrol, which is a quite interesting project in my mind, because it has on the one hand, a hard, rather technical side, which involves the reconstruction of a 13-story tower, former nurse residences from the 70s, which is now used for the university, which includes the total gutting of the premises, but without demolition of the building, because it's not allowed due to its historic facade. And it also includes cutting-edge green infrastructure, which is quite innovative, from cooling, heat pumps and solar power to a very interesting prosumer concept, where some local facilities are integrated into one prosumer concept, and so they are able to share energy with each other. And and also includes smart regulations and control systems, and efficient greening and roof garden. And so considering all these factors, high-end building certification for energy efficiency and sustainability will be achieved for the project. But there is also a very interesting soft side to the project, which includes keeping intact the historic facade, but also reusing loads of the building materials which are taken out, but also recycling the building materials which cannot be reused in collaboration with a startup, and also operationalizing a recycling concept after using the building, and also a very far-reaching sustainability controlling will be established, and there is also a sustainability ambassador program for students, which is maybe quite potent, because the students, after having completed their education, will go into several hospitals in Austria and also other countries. And so the idea is that they will take their awareness for sustainability with them. And there is also green education in the curricula of the various studies, which is also combined with how the building is made, for example, using the rooftop garden and using the medical herbs which are grown up there, to learn about them. They tried to achieve funding through the LIFE program, which was unfortunately unsuccessful 2 times. So they applied in 2023 and 2024 unsuccessfully. Fundable projects within the LIFE program and the sub-program of circular economy and quality of life, with the subtopic New European Bauhaus, would have been innovative green building projects, which also have a piloting or a pilot project function to them. It's kind of a high risk, high reward scenario, because on the one hand, if you're successful, you would achieve a non-refundable funding of up to 10 million euros. But on the other hand, there are only approximately 30 projects which are funded through this instrument every year, and the ratio of submitted to funded projects is around 20%. So our learnings and takeaways from supporting this project are that, first of all, you need a high degree of innovation, because otherwise you don't really have a chance to get funding. The project we supported was chosen out of 13 different projects which were brought to us. It was one of the most innovative ones out of them, but still 2 times unsuccessful. And it's what we also learned is that especially in the healthcare sector, it can be quite difficult to be innovative because of the high regulations or higher regulations compared to other industries. Another downside is the time factor, because the application is like at least 70 pages, and it takes months of men and women days to process it. And the processing time, therefore, is at least a year from really starting the application to being granted the funding afterwards. And of course, there's also a cost factor to it, which is not just internal costs due to employees working on the application, but external support is most likely needed for applications of this size, which often costs tens of thousands of euros, and some documents will additionally also likely have to prepared specifically for the application. Yes, as I mentioned, the risk factor is there, because the funding ratio is relatively low and the competition is high. And also, even if you're funded, there are strings attached, because the project accounting and controlling afterwards is quite stringent. So there is also additional effort tied to it. But there are also upsides in my view, because as I said before, the reward is quite high in case you're funded. And it's not just the money, but also the visibility, because you really stand out from other projects due to the pilot project and pioneering status of EU funding of this kind, and also the European reach. That was just a very short keynote from my side. If you want to get in touch, please feel free to contact me or ask a question afterwards. Thank you very much.
Thank you very much, Philip. I think you said it very nicely. Of course, it was really disappointing. I think we were all very excited when we identified the LIFE program as a possibility for funding for such really innovative and promising projects. And then not being successful, it shouldn't mean that people should be discouraged, but as you say, it's difficult to do. I really appreciated the hard side and the soft side, and particularly the dimension that says that when you have a sustainability or a greening project, the project itself needs to be green as well in a way. So this is quite important and quite interesting to keep in mind. So thank you very much. It was really, really hands-on and on a level, on a dimension, the financial aspect, and we'll return to that in the discussion that is usually fundamental to getting such projects kickstarted. So we keep a lot of the information that you put on the slide, and we'll return to that in the discussion. So thank you very much. And we go now from Vienna to Catalonia, almost, because David is not in Catalonia at the moment, but at least, you know, he's going to talk to us about Catalonia and the initiatives that you have taken, David, with Mutua Terrassa, and in general, in making sure the health system there is more sustainable. So over to you. Thank you.
Thank you very much, Dimitra, for the invitation. Following the policy brief on how healthcare facilities can reduce their environmental footprint, I would like to briefly highlight how collaboration between health providers, governmental institutions, academic partners, and community stakeholders can support the generation of research evidence needed to adapt health systems to climate-related risk. In this slide, you can see how our organization mitigation and adaptation strategies are embedded within a broader climate action roadmap where research plays a key enabling role. One of the key enabling factors in our context has been the organizational structure of our healthcare provider, which operates across the full continuum of care, including primary care, hospital services, and intermediate care, within a defined territorial catchment area of approximately 300,000 inhabitants. This integrated model allows us to access longitudinal clinical, pharmacological, and biological data collected over more than a decade across different care settings, enabling us to map patients' trajectories across the life course. Through ongoing research projects, we are beginning to explore how patterns of clinical vulnerability may interact with environmental exposure, such as extreme heat or air pollution, with the aim of identifying climate-sensitive susceptibility profiles among individuals living with chronic conditions. In the next slide, you can see how this work is supported by means of a multidisciplinary consortium coordinated through the Health and Climate Change Chair at the University of Barcelona and Mutua Terrassa, which brings together clinical data, meteorological information, environmental measurement, and biological markers within a shared analytical framework. This collaborative structure enables the integration of routinely collected health system data with environmental and meteorological information provided by public agencies, as well as with expertise from academic institutions and engineering partners. Within this framework, several complementary studies are currently underway, like a retrospective study, population-based analysis covering the last 8 severs of routinely collected clinical data in examining how extreme temperature episodes may be associated with destabilization of chronic cardiovascular and metabolic conditions. In parallel, a housing-based observational study in exploring how indoor thermal conditions may influence health stability among highly vulnerable individuals with chronic disease during periods of extreme heat. We are also conducting an epigenetic study in individuals at risk of early cognitive decline, investigating whether environmentally responsive molecular markers may help identify subgroups of patients with increased susceptibility to environmental stressors. We, in addition, have ongoing work is assessing how ambient temperature may influence long-term metabolic outcomes following bariatric surgery, while other projects are investigating the role of environmental pollutants in early neurodegenerative processes. Collaborative initiatives with engineering partners are also supporting the development of digital tools designed to anticipate climate-sensitive in patients with chronic based on the integration of clinical environmental data. Naturally, cross-sectoral collaboration raised several challenges, particularly in relation to data governance and interoperability. Sharing data between healthcare providers, environmental agencies, and public administration requires robust legal frameworks, clear governance agreements, and a strong institutional trust. In the next slide, reflects a broader policy science gap where frontline clinical and environmental evidence is not always effectively translated into policy implementation. Over time, these barriers have been addressed through formal data sharing protocols and secure analytical environments that enable joint analysis without compromising patient confidentiality. While such collaborations demand sustained coordination, they also generate important co-benefits, including improved targeting of preventive interventions and better anticipation of seasonal health system pressures during climate-related events such as heat waves. In the next slide, this type of research, you can see, that is essential if health systems are to move from generic heat health warnings toward targeted vulnerability-informed preventive responses. Ultimately, our experience suggests that adapting health services to climate-related risks depends not only on technological innovation, but on the capacity of institutions to collaborate across sectors and to translate data into anticipatory action. Thank you very much for your attention.
Thank you very much, David. A couple of really key points here. First of all, the link between adaptation and mitigation, as we've been talking about. Secondly, the importance of multi-stakeholder collaboration. That was clear in the previous presentations as well, but you gave us a very, very obvious example of how many different actors need to come together to actually make that work. Two things that I really appreciate here is, of course, coming from the Observatory, the evidence to policy gap and how we really need to make sure we bridge that gap, because otherwise implementation doesn't happen. Links back to previous comments also from Maria and from Philip. And I think looking at the chat very briefly, there's a lot on data and evidence there to guide actions. So that is also a crucial point, as you mentioned. And so issues like interoperability and actually having the right data on the adaptation side, but also for the mitigation part of the story is really important. So we will come back to that in the discussion, I'm sure. For now, I say thank you very much. This was a very, very illuminating example from Catalonia. And we pass to our last spotlight, to Dorota. We already saw some of WHO's work on the slides before, Dorota, but you hold in your hands a lot of the technical support for those countries that want to implement relevant measures. So please tell us. Thank you.
Thanks a lot, Dimi, and I'm really delighted to be part of this discussion and share a few points of the WHO regional work. So we have just heard these three truly impressive and inspiring examples of initiatives with slightly different focus and undertaken at slightly different levels. The good news is that these are not the only examples, that the interest and the recognition of the relevance of this agenda is growing, and there are many examples and experiences of countries undertaking it, regardless of the model of health system, private or public based. At the same time, while we have in Europe some true champions in this work, there are also countries that are at the very beginning of this transformation. And this is one of the roles of WHO to facilitate bridging the gap and making this transformation feasible for everyone. So zooming out from specific projects, let me highlight or maybe reiterate a couple of points. That first, when we talk about the work to increase environmental sustainability, strengthen climate resilience, and reduce carbon footprint, we need to take this integrated thinking, and we need to see these actions as a continuum. It's not either or. While specific projects may focus on some aspects because of the priorities, capacities, local needs, they need to be seen as part of the bigger picture, involving different actors, but being part of this transformative change. You have seen this image from the WHO operational framework, but I would like to emphasize the point that action, bottom-up and top-down actions, they need to go hand in hand. So good examples, innovative solutions developed, created at the healthcare facility at the regional level, they need to find a way to be communicated to inform changes in the whole health system, changes that would then in return create conditions that enable continuing, advancing and scaling up actions at the local level. And then I think this was perfectly illustrated by the intervention of Maria. And whether these are changes to the national level health information system, whether these are modifications in clinical guidelines or revisions of some clinical pathways, or some advice given to the very hard infrastructure, these are the domains where this mutual exchange is instrumental. Another point I would like to stress is about integration, that considerations of environmental sustainability, climate dimension for the health systems cannot be seen as something, as an add-on, something external, but still a lot of effort is needed to invest to make it really not only an integral component, but as an indispensable condition for the sustainable functioning of health systems, including providing quality care, generating also some economic gains while maintaining and in some instances improving the quality of care. So what we do, just to give a few examples, the interactions with the countries. I mentioned that there is a growing interest, and we are working with countries who are coming with different requests or interests, like some need support in developing a method how to conduct baseline assessment of greenhouse gas emissions. There are questions related to generating relevant indicators, or how to initiate voluntary action even with own resources. So there is quite a diversity of needs and opportunities. The next keyword I would like to use is partnership and peer-to-peer learning. There is such a huge potential to tap in with different solutions that we really need to create opportunities to present and to share it. The policy brief that has been introduced at the beginning is giving visibility to some of the examples. But from the WHO perspective, I would like to mention a regional initiative, so-called Environment and Health Partnership for Health Sector Climate Action. It's the partnership, it's a community of practice established in 2023, country-led initiative, and Ireland is leading this initiative. We are very happy to see that this partnership is growing and has now 12 member countries. And the idea behind is to create a platform for a very practical exchange of experiences, but also sharing questions and challenges. And also to promote and to present some solutions and to discuss some specific issues. I just would like to share examples of these so-called thematic deep dives held by the partnership around the topics identified by this community, online meetings open to the interested audience, tackling different aspects, whether it's transport, whether it's the emphasis on climate adaptation, or focusing on pharmaceutical stewardship, keeping in mind this the relevance of pharmaceuticals in the procurement, in in the greenhouse gas emissions and carbon footprint. So this is one of the platforms, and the invitation for others to join is open. But these are, of course, not only our regional activities, but many of you might be familiar with the global initiative called ATTACH, Alliance for Transformative Action on Climate and Health. This is a global community of practice involving many countries, including the European champions. And they also work on developing practical guidance and advice how to move this agenda. And I'm just bringing the titles of two recent publications focusing on the decarbonization, on how to measure greenhouse gas emissions from the health sector. And these recent publications, they are not the only products, but there is quite a range of WHO documents, guidances, operational frameworks that support action related to assessing vulnerability, assessing some specific features of climate vulnerability, etc. And we, from the perspective of the regional office, are working with countries to make these different tools, methods, and frameworks useful and relevant for our countries. And with this, I would like to thank you for attention.
Thank you very much, Dorota. It's really interesting and also very important that you shared the resources with our participants. Very important, the word partnership, working together. We heard it in the previous spotlights as well. But you gave us very obviously the link to EHP, the link to ATTACH. I think these are resources that will be key for colleagues. And the other thing that I really appreciate is the concept of integration. So we should be thinking about this type of action not as an isolated add-on, nice to have, but as fundamental part of making our health systems fit for the future, basically. So that's really important. Thank you very much. Stay on, and I would like to ask all of the rest of our panelists to switch on their cameras as well, because now we have about 10 minutes for some of the questions from our audience and some of the questions we ourselves might have for each other. And excuses for Nicole, who had to leave, unfortunately, abruptly. But I think we are really interested to hear, A, what's coming in from the chat, and some of you are already active there, I see, and B, what your reflections are now that you've heard everybody else. So Erica, over to you. Tell us what's going on.
Okay, it's been a very, very lively chat box. Lots and lots of comments and questions, and some really quite big questions. So when we talk about the health workforce, someone pointed out that we need to include administrative and management staff, not just the clinical frontline staff in sort of developing carbon reduction policies. But how do we hold them accountable? So do we need sort of accountability frameworks for hospital boards and managers to scale up action to reduce the carbon footprint of individual facilities? Should we be having some kind of targets for individual facilities? If we are going to have targets, how are we going to measure carbon reduction of individual facilities? Or indeed, should we not be looking at individual facilities? Should we be looking at whole health systems, either at the regional level or at the national level? The complexity of implementation is one of the big barriers to these policies. Well, what are the other barriers and how do we overcome them? Another really big question. And then how do we get people involved? How do we overcome the hesitancy from actors who are interested in reducing carbon footprint within the health system, but are worried about the cost? They're worried about the financial burden that goes along with it. So many questions. Please feel free.
Thank you, Erica. And I think very much aligned with what we have been talking about in preparation for this webinar as well. So I'm looking to our panelists to somehow actively signal that they want to come in for any of those questions. I think very concretely the issue of implementation that you mentioned, Erica, perhaps thinking about, we talked about financial barriers very clearly. There are other implementation barriers there, as perhaps out of personal experience, colleagues can bring in what they think is most important. Seeing as we don't have very long left, perhaps we need to focus on what is, let's say, the key message that we want our participants to take away with them when they leave today. Maria, over to you. Thank you.
Thank you. There are many barriers to implementation, no doubt, but if we try to focus on the financial ones, which again is of course linked to many other things, being the structures, the leadership, the mandate, everything else, I think definitely there is a problem that we are lacking the initial investments, and I made it a point already, but when we make our calculations, it is really a matter of what perspective we are looking at the business cases from. If we are looking at a 2-year perspective, I would looking at a 10-year perspective. Since we made the analysis of the metal instruments in Denmark in 2022, the price on single-use metal instruments has more than doubled. Mm-hmm. We made the calculations. We did not think about that. We just took the price right now, and then we made our calculations, and we thought, well, 2 years, 3 years, something like that. But we really need to broaden our perspective and say, what is the geopolitical situation? What is climate change doing to the market and the logistics? So what right now might not be affordable could be the very best idea in just 3 years. So mm-hmm. we need to embrace the complexity of what is affecting the price of the market and the use of what we're doing.
Okay, I think that's really important. I think in a way, making the business case is always key. I think we saw from Philip's presentation that getting investment somewhere else, which might be the alternative, is not always as easy. I personally think, before we come to you, Dorota, there is of course a political dimension behind it, and there will be political windows of opportunity for more funding or less funding depending on the context. And that we need to recognize that as well, and work accordingly. But this is really key points. So thank you for that, Dorota. I see you have your hand up.
Mm-hmm. Yeah, thank you. Of course, this fully agree with what has been said. I think that we are also too often talking about the cost and not about the investment. That it's part, that these very immediate short-term initial costs are highlighted, but then the longer perspective of the benefits are not seen. But in addition to this, and linking to this diversity of people whom we label health workforce, from clinician to manager, it's also to diversify the entry points. That when we come with environmental sustainability argumentation, there are groups of health professionals to whom this doesn't speak. It's completely a strange environment. So trying to find these different entry points, whether it's a quality of care, whether it's economic aspect, whether the hospital manager think, is your hospital placed in the flood-prone area? Is it something for you to think in terms of preparedness? So also diversifying the entry point, and that brings me to the point about really working across professional domains, across the lingos that we are using, certain way of thinking and formulating the problems. And I think this is also relevant to contribute to drive the change. Thank you.
Thank you, and links very nicely to your point about both bottom-up initiatives and top-down support that is needed. I think what you bring in terms of, it links to integration as well, right? So if we can argue for greener health facilities while arguing actually for something else, so better energy efficiency, which is better for financial reasons, right? So then that can be, it's a co-benefit in a different way than we normally use it. But then this is a way to implement, perhaps when the ground is not necessarily fertile for initiatives that only are focused on environmental sustainability goals. There are, of course, many areas where it is enough that it is environmental sustainability that's driving, and that's, of course, what we like to see, but it's not always what we find, right? Yes, of course. Okay. Erica, did you have any additional points? I mean, those were already quite a few that you brought up. I don't know if there is anything you want to highlight that we haven't touched upon yet.
Yeah, maybe.
Oh yeah, please go ahead, David.
Yes.
You were so polite, and I didn't realize. Please go ahead.
I would say that from my perspective, it would be also very very important, apart from the financial issue, the quality of data and to share data among the whole healthcare sectors. I mean, it's very difficult to obtain data, longitudinal data from the hospital and the primary care settings. Therefore, I think that this is something that is a problem in the whole European area. I mean, there is not only a problem that we have in our country, but in Europe in general, we have if a scarcity of good data and to share data, good quality data from a clinical perspective to potentiate projects that can be very essential to demonstrate the link between health and climate change.
Absolutely, thank you. And I think I mentioned before, if you look at the chat, the first things that started coming up as the webinar was ongoing was really about what's the evidence on this, what's the evidence on that. And obviously, if you're thinking about, well, obviously evidence on the environmental footprint of individual pathways or technologies, but first and foremost, we need to be able to track the pathway across sectors, as you say. So it's, again, a matter of integration. Obviously, we need specific data on these topics, but also fundamentally better data to be able to understand how our health systems work. So it's a really important point. Yeah.
I think there is something that there is a European space data that is ongoing. I mean, that maybe that can improve this problem.
Yes, we all hope, yes, and are confident that will be the case. So yes, European data space, absolutely right. Philip.
Yeah, just very quickly coming back to the previous question regarding bottom up or top down, which one is more important? I just wanted to share a bit more of a spotlight on Austria, because I think in Austria it's really much important to have those bottom up initiatives, because I really realized in the course of the project that it makes a big difference whether there are some motivated people, so to say, working in a hospital or not, because they bring down really great projects. And luckily in the past years, it was still possible to get funding for them. But yeah, now in the future, it will likely get more difficult. And so I guess it becomes even more important to fight for funding in order to get done what is important for you, which is hopefully sustainability.
Thank you. That's a really important point. It brings us to the end as well, because I think, as you mentioned, increasingly challenging to perhaps secure the necessary funding given other priorities. Increasingly important to have people within the system at different levels who are motivated, but who also work together, that we think about these considerations as part of overall health system performance, not as isolated incidents. And of course, the absolute basis, as we said, of collaboration, working together in different areas. We at the Observatory will keep working on this topic in any case, and we will keep putting it in the spotlight, hopefully with all of you together. And we, at this point, I think we say goodbye to all, big thank you to all our speakers, and goodbye to our participants, and hope to see you at the next one. Thank you very much.